When you use an inhaler, a cloud of medicine passes through the mouth and into the trachea. As this fine mist travels deeper, it reaches the tight, constricted muscles around the airways. The medication sends signals to the muscles to relax, causing the airways to widen. And as they open up, it allows the air to freely flow, which helps you breathe.
People who have lung conditions like asthma or COPD often take their medications using a handheld device called a metered dose inhaler, or MDI. A metered dose inhaler sprays medicine through your mouth so that it can reach your airways. If your inhaler is not used the right way, some medicine may not enter your mouth, or some may remain in the back of your mouth. Either way, it may not reach your airways where it is needed. This video will show you the general steps for using an inhaler correctly. It's important to follow the instructions that came with your metered dose inhaler. A metered dose inhaler has three main parts: the mouthpiece cover, the plastic sleeve with a mouthpiece, and the medicine container. Before using your metered dose inhaler, remove the mouthpiece cap and shake the inhaler. If this is the first time you are using your inhaler, or if you haven't used it in a while, you may need to prime it. Check the instructions for how and when to do this with your inhaler, as they can differ depending on the type of inhaler and medicine. When you're ready to use your inhaler, stand or sit up straight. Breathe in deeply and breathe out completely to empty your lungs. After shaking the inhaler, put the mouthpiece in your mouth and close your lips around it to form a tight seal. As you breathe in through your mouth, press down firmly on the top of your inhaler to release one puff of medicine. Keep breathing in slowly through your mouth for 3 to 5 seconds until your lungs are completely full. It is recommended to hold your breath for approximately 10 counts. Finally, breathe out slowly through your mouth. If your medicine dose requires 2 puffs, you may need to wait before taking the second puff. Follow the instructions that came with your inhaler to know how long to wait between puffs. After using a steroid inhaler, rinse out your mouth with water and spit it out. It's important to keep your inhaler clean so that it works properly. Check your inhaler's instructions for the right way to clean it. Proper use of your metered dose inhaler may help you control the symptoms of your lung condition.
When asthma is at its worst, both inflammation and hyperresponsiveness occur. Airways are obstructed through swelling, bronchospasm, and thickened mucus secretions. Asthma is mostly controllable, but severe asthma typically doesn't respond to standard treatment. The result may be long-term structural changes or remodeling in your airways. Research now shows that different kinds of asthma are defined by the different cellular pathways to inflammation. The National Institutes of Health report that about half of people with asthma have type 2 high asthma, caused by increased levels of inflammatory cells called eosinophils in the lungs and blood.
Asthma is caused by inflammation in the airways inside the lungs, also known as the bronchi and bronchioles. Quite often, airborne allergens like dust mites, pollen, mold, and animal dander will cause inflammation. This causes the muscles around the airways to react by tightening, thereby constricting the airway. Additionally, airway walls begin to swell and cells begin to produce more mucus than usual, which further restricts airflow in the lungs. You'll feel a tightening of the chest, shortness of breath, and wheezing. To combat these symptoms, quick relief medication is often inhaled directly into the lungs, which causes the muscles to relax and opens the airways for oxygen to pass. Quick relief medications are often only a short-term solution. Your doctor can work with you to develop a long-term asthma control plan.
That anatomy books often state that direct sympathetic innervation of the airways via norepinephrine causes bronchodilation. Norepinephrine actually has very little effect on the airway diameter, which is why circulating epinephrine has a much greater effect. Note, asthma is a condition where the airways can become inflamed, they swell, and you get bronchoconstrictions, they narrow, and you have production of extra mucus. It makes it very difficult to breathe. It looks like this: normal asthma. So a treatment are these short-acting beta-2 agonists where the airways can get wider and easier to breathe. So here's an inhaler, which then you inhale in these airways, these beta-2 agonists, which then bind to this beta-2 receptor, and shing, you get these airway dilation. And so stimulation by these beta-2 agonists can cause bronchodilation to make breathing easier.
Tiotropium, also known by the brand name Spiriva. Tiotropium belongs to the anticholinergic drug classification, also known as cholinergic antagonists. Let's talk a little bit about anticholinergics and how they work. Acetylcholine is the main neurotransmitter involved in our parasympathetic nervous system, also known as the rest and digest nervous system. Acetylcholine is where the name anticholinergic comes from. So acetylcholine normally binds to receptor sites in the parasympathetic nervous system, causing rest and digest functions. Normal rest and digest functions include anything that you do when you're resting and digesting. They include increased salivation and digestion, decreased heart rate and blood pressure, bronchial constriction, and more. Tiotropium is an anticholinergic, which means that it blocks or inhibits acetylcholine binding sites, which causes the opposite of the normal rest and digest functions. So tiotropium would cause decreased salivation and digestion, increased heart rate and blood pressure, bronchodilation, and more. You can see that all of these effects are actually just the effects you'd expect to see in the sympathetic or fight or flight nervous system. Again, that's because tiotropium is an anticholinergic, so it does the opposite of rest and digest. Now, tiotropium is administered as an inhaler rather than, say, a pill or injection, and inhalers don't generally produce systemic effects, which are effects that you'd expect to see throughout multiple systems of the body. So because it is inhaled, it acts locally in the bronchi, primarily producing the effect of bronchodilation. Bronchodilation is the widening of the bronchi, resulting in a more open airway and making it easier for people to breathe. Due to tiotropium's effect of dilating the airway, it can be used in the maintenance of asthma. Tiotropium can also be used in the maintenance of bronchospasms associated with chronic obstructive pulmonary disease, or COPD, which includes asthma, chronic bronchitis, and emphysema. Tiotropium has an approximate onset of less than 30 minutes, while salbutamol or Ventolin typically has an onset of less than 5 minutes. This is why salbutamol is considered the go-to rescue inhaler for asthma attacks, while tiotropium is considered a maintenance or controller inhaler. It's also good to know that tiotropium is often given once per day due to its relatively long duration of 24 hours. Some of the side effects of tiotropium include a dry mouth or an unpleasant taste in the mouth, headache, anxiety, and nervousness. Less common side effects include tachycardia, arrhythmias, and paradoxical bronchospasms, which is the rapid onset of bronchospasms shortly after administration of an inhalant. Paradoxical bronchospasms can be life-threatening and may occur with excessive use of tiotropium. Tiotropium may cause worsening of narrow-angle glaucoma and urinary retention. Tiotropium is structurally similar to the drug atropine, so patients who have a history of hypersensitivity to atropine should be monitored very closely for similar reactions. Exercise caution in clients with narrow-angle glaucoma, prostatic hypertrophy, clients who are breastfeeding, and more. Always remember to assess and monitor for side effects of tiotropium. You can encourage clients to rinse their mouth after use. During an asthma attack, remember to use a rescue inhaler like salbutamol to open the airway quickly. If your client is going home with tiotropium, always ensure that they understand how to properly administer their inhaler by getting them to perform a return demonstration. There are two pretty common inhalers made for tiotropium, the Spiriva Respimat and the Spiriva Handyhaler, each of which must be set up correctly, so be extra careful to follow their instructions provided. For example, the Spiriva Handyhaler requires these special Spiriva capsules, which are then pierced using the device. These capsules look similar to capsules that one might take orally, however, they are for inhalation only and are not to be swallowed like ordinary capsules. Remember, the medication will only work if it gets into the lungs via inhalation. Also, a good general rule to teach for inhalers is to inhale for 3 seconds, hold for 10 seconds, and exhale slowly through the nose.
So let's look at the mechanism of action of ipratropium bromide. There are 5 types of muscarinic receptors, which include M1, M2, M3, M4, and M5. Muscarinic type 3 receptors can be found on bronchial smooth muscle cells, as well as exocrine glands. It is these muscarinic type 3 receptors which are the target site of ipratropium bromide. When acetylcholine is released, it will bind to its target receptor. In this case, the muscarinic type 3 receptor. When these receptors are stimulated, it causes an intracellular cascade to take place, which we will discuss shortly. This intracellular cascade causes a rise in intracellular calcium, which causes muscle contraction by increasing actin and myosin cross-bridge formation. Therefore, muscarinic 3 receptors cause bronchial constriction when the neurotransmitter acetylcholine is bound to it. Ipratropium bromide is a competitive inhibitor of acetylcholine, binding to the muscarinic type 3 receptor and inhibiting acetylcholine from exerting an effect. This will then lead to relaxation of bronchial smooth muscle, leading to an increased airway diameter and easier passage of air, making it easier to breathe.
Chronic obstructive pulmonary disease, or COPD, is a progressive inflammatory lung disease characterized by increasing breathing difficulty. Other symptoms include cough, most commonly with mucus, chest tightness, and wheezing. COPD develops as a result of long-term exposure to irritants such as smoke, chemical fumes, or dust, and may go unnoticed for years. Most people show symptoms after the age of 40 when the disease is already in its advanced stage. The lungs consist of millions of air tubes or airways called bronchi and bronchioles, which bring air in and out of the body. These airways end with tiny air sacs, the alveoli, where the gas exchange process takes place. Repeated inhalation of irritants results in a chronic inflammatory response, which brings in a large amount of defensive cells, along with inflammatory chemicals from the immune system. Inflammation of the airways causes them to thicken and produce mucus, narrowing the air passage. This is known as chronic bronchitis. Inflammatory chemicals also dissolve alveolar walls, resulting in destruction of the air sacs. This is emphysema. COPD is basically a combination of these two conditions. Tobacco smoking is accountable for about 90% of COPD cases. These include current, former smokers, and people frequently exposed to secondhand smoke. Extended contact with harmful chemicals such as fumes from burning fuel or dust, at home or workplace, may also cause COPD. Genetics has been implicated in a small number of cases. Notably, a condition known as alpha-1 antitrypsin deficiency, or AAT deficiency, has been shown to increase risks for COPD and other lung diseases. AAT protein protects the lungs from damaging effects of enzymes released during inflammation. Low levels of AAT make lung tissues more vulnerable to destruction when inflamed. While people with AAT deficiency may develop COPD even without smoking or exposure to harmful irritants, AAT deficient smokers are at much greater risk. COPD is diagnosed based on symptoms, history of exposure to irritants, and lung function tests. The major test for COPD is spirometry, in which the patient is asked to blow into a tube connected to a machine, a spirometer. Spirometry evaluates pulmonary functions by measuring the volume and the speed of airflow during inhalation and exhalation. There is no cure for COPD, but treatments can relieve symptoms, prevent complications, and slow down progression of the disease. The first and most essential step to treatment is to stop smoking and/or improve air quality at home and workplace. These are also the most effective measures in preventing the disease. Other treatments include medication, bronchodilators are used to widen the airways, steroids to relieve inflammation, vaccination against flu and pneumococcal pneumonia. This is to prevent serious complications COPD patients may have with these respiratory infections. Supplemental oxygen. This can improve quality of life provided that the patient no longer smokes. Breathing exercises and other therapies as part of a pulmonary rehabilitation program. Finally, surgery may be performed for severe cases when other methods fail. Surgical procedures include bulectomy, lung volume reduction surgery, where the damaged parts of the lung are removed, and lung transplant, where the entire diseased lung is replaced with a healthy lung from a deceased donor.